This episode is sponsored by the Bridge to Recovery, a nonprofit program on 115 acres near Bowling Green, Kentucky, a tranquil place where they've been changing lives for over 40 years. Their people improve their quality of life by acknowledging past emotional wounds and healing from all forms of trauma. The CEO, Paul Hamlin, has been a friend of mine for 20 years. Call him directly at 858-945-7848. That's 858-945-7848. Or you can learn more about the Bridge to Recovery by clicking the link in the show notes or visiting thebridgetorecovery.com. Thank you for listening to The Path to Authenticity. My name's Tom Gentry. I think of this show as the opposite of small talk. You'll hear real conversations with real people who know who they are. We talk about what makes them who they are, how they became who they are, and how we might become truer expressions of who we are.
This is Michael Weiner, and this is The Path to Authenticity.
My name's Tom Gentry. Thanks for listening to The Path to Authenticity. You know, I really enjoy doing this podcast. I love having these deep conversations with people. It's, it's one of those things that doesn't feel the least bit like work. I just kind of get lost in it when I'm doing it. I'm really in the moment. I love it. That being said, my least favorite part of all of this is actually what I'm doing right now. This monologue thing that I do to begin each episode. I just, a lot of times it just feels agonizing. It's really important to me to come across as genuine and authentic. I don't want it to feel rehearsed or contrived. But that being said, it's kind of hard to tee these conversations up without at least having some notes, but I'm not really interested in writing a speech. I'm more of a conversation guy. I don't want to bore anybody out of their wits. So, just wanted to be real and put that out there that, this part of it's tough for me. That being said, this is the first of 2 episodes with a psychologist named Dr. Michael Weiner. He's a drug and alcohol counselor, Ph.D. level. He's been around for a really long time. He was a college professor, taught at Stony Brook University. He taught at the University of North Carolina, Greensboro. He speaks at a lot of conferences. He's, also a writer. He's published a lot of articles on addiction. You can find him out there in the online world. There's a magazine, one of the trade magazines is called Addiction Professional, and he has articles published there that you can find. But he's got a practice in West Palm Beach called Lifespan Recovery Management, which just the name of it just kind of speaks to his beliefs about addiction treatment and how we need to regard the care that we give someone for their addiction or for their substance abuse or dependence. Because, it's fairly well known that addiction is, it's been characterized as a chronic disease by the American Medical Association. That being said, we call it a chronic illness, but from a functional standpoint, in the world of addiction treatment, we kind of treat it as if, in many ways, as if it's more of an acute illness. So we look at it like you go away to rehab, you go to treatment for 30 days, and, you get the tools that you need to learn how to be clean and sober. And then if you relapse, it's a failure. Where if we're really going to look at it like it's a chronic illness, that doesn't make a whole lot of sense. So that's sort of what this conversation centers on. So Michael and I kind of get in deep about all this kind of stuff. And I think it's really important. It is to me, as someone who got clean and sober at a really young age, at 23 years old, when I was the youngest guy at the facility that I went to. There was only one other guy in his 20s. This is the mid 90s. Everyone else was 40s, 60s. My roommate was 67 years old. There was an 88-year-old there in the same program that I was in. Now, that's unheard of. With the opioid epidemic, what that has brought is, a lot of young people showing up in addiction treatment. And so now you walk through an addiction treatment facility, you're going to see a lot of people 26 and younger. Sometimes, someone age 30 is sort of an aberration, let alone a 40-year-old or a 60-year-old. Those folks at this point, if they get to treatment at that age, they feel pretty out of place because most people there are really young. And that being said, I feel like we really need to take a close look at how what messages we're conveying to this audience. Are we considering our audience? And Michael and I talk about, some ways that we might be able to do a little bit better at that. But anyway, a friend of mine called me a few weeks ago, one of the guys who I had on the podcast not long ago, and said he had spoken to Michael, and Michael asked him if he thought Tom would have him on the podcast. And it just kind of touched me. It made me feel really good that Michael, anyone, but, Michael especially would want to be on this podcast. Just meant a lot to me. So I picked up the phone and called him right away. I've known him kind of casually for probably a decade, maybe a little more than that. We've shared meals a couple different times, but we've never really had a conversation like this. And it was really a pleasure. So I hope you enjoy it. Dr. Michael Weiner.
Just the product of some bad seeds, just some guys that ruined the weeds. But we learned.
I took a look at your CV.
Right.
And done a lot of teaching, haven't you?
Yes, I have. University of North Carolina, Rochester Institute of Technology. That was a ways back.
Mm-hmm.
I guess I can tell you that it was the Rochester Institute of Technology that I really credit with saving my life. They really stood behind me a long time ago. At first, they suggested I get treatment. After a while, they seemed to have thought that it was mandatory. So
Okay.
That was a long time ago. And I just can't imagine another employer, let's say, going as far as they did. They were really good. But teaching has always been important to me. Some of the articles on the resume, let's say, they have something to do with teaching.
Right.
And a lot of those publications, myself and Dr. Tammy Malloy, people like Drs. Nayless Diaz and a lady named Gail, we all did it together. We presented at conferences, and always feels good to pass the word on to other people.
Mm-hmm.
So teaching has always been even when I work with patients in the office, there's teaching involved. So because I do I try to get them thinking about treating a chronic disorder for a lifespan.
Right.
It just seems like that's the way lifespan disorders need to be treated.
Yes.
So we look at it a different way, and I think it lifts some of the stigma at the same time. If you wanted me to go into that a little more, just tell me.
If you could, just tell, for those who don't know, what you do day to day, what's your life look like from a professional standpoint.
I do as little as possible, and sometimes it gets to be too much. But on a daily basis, I have a private practice down on Clematis Street. It's not a big private practice, but I choose to keep it that way. I'm a consultant for the Palm Beach Detox and Wellness Institute, which a lot of people still may remember as the Palms at Good Samaritan Hospital
in West Palm Beach.
And I do some writing, and the writing, it's not me who's passing the word. There's people like a man by the name of Michael Botticelli did so much. Dr. David May Lee did so much. But I really feel there's sort of a coming together of people who are beginning to look at, are we really treating a chronic disease? I think we're treating a chronic disease with an acute care model. And
what's that, just in layman's terms, what does that mean for someone who doesn't know anything about addiction treatment?
At the present time, I feel like I might be getting a cold, okay? Now, a cold is an acute episode. If I get a cold, I'm probably going to be, stuffed in the head more than now, sneezing, coughing, be unpleasant for about 4 or 5 days. A physician might tell me something like, take this medication or take some aspirin, and you'll be fine in 5 days to a week. And I think most people would agree with that scenario pretty much. It could be a cold, it could be a flu, it could be various other illnesses. I could break my leg, but that's an acute care occurrence.
Right.
You treat the leg, and it gets better. Okay. With my cold, or with the leg, so let's say I get a cold, I treat it, take aspirin, drink juices, and I'm better in 7 days, okay? Everything's going to be great, but if a couple of years down the line I get another cold, I'm going to do the exact same thing. Make sense?
Yeah.
But that's not how a chronic disease is treated. My wife has hypertension. It's a chronic disorder. They're going to be monitoring it for the rest of her life. She's going to have some special checkups. There's at least one time where she had to go to a hospital, and I equate going to the hospital with, let's say, residential care, okay? So with my cold, once it gets better, I'm going to do the exact same thing sometime down the road. My wife, or a person who has diabetes, their chronic disorder is being treated as a chronic disorder. In other words, it's lifetime. There's always going to be checkups. There's going to be times when a person who's diabetic, their symptoms recur, so they have to treat it with a higher level of care, okay?
Right.
That's just the way it is.
And no one judges them when their symptoms recur.
True. Actually, maybe we'll get back to this, but I have a feeling we who work in the field are the ones doing some judging. I'll tell you about that. But I was treated for addiction in 1982, 83, okay? I was told it's a chronic disease. Does it make sense that I have not seen a treatment professional since 1983? Doesn't make sense, does it?
No.
There's lots of ways we hurt ourselves by treating it as an acute disorder. If I would, start drinking or drugging again, I'm going to start to do the same thing I did all over a long time ago, right? In a way, a cold gets better, let it go. A couple of years later, it happens again, you do the exact same thing. With addiction, I think what people do, people go to treatment, which is an incredible experience. And actually, when I just said that, I realized that I used the word treatment to cover everything. I mean, I actually was thinking residential care.
Right.
If I have a chronic disease, I need to be in treatment forever. Okay.
Right.
There's no such thing as a first treatment, no such thing as a second treatment. You could say I had my first cold and I had my second cold, but with a chronic disease, treatment needs to be continuous. I feel like we do very well at what we do. You know, some people say, you know, they're always coming up with different ways to do treatment. I don't think there's anything wrong with the way we do treatment. I think what we have to change is how it's dispensed. I call what I do lifespan recovery management. Let's say a person comes to me. They want an assessment. They want to see where they're at, what they need. I do an assessment. The assessment, I would stick very closely with the diagnostic, with the ASAM criteria 2013, because when I'm doing an assessment, I'm measuring 6 different areas of a person's life. Do they need detox? What are their medical issues, emotional issues? Are they really motivated to do recovery? What are the possible consequences of getting back into using? And what's their environment like? Okay, it's an assessment. Assessment might indicate that this person meets the ASAM criteria for IOP.
Mm-hmm.
Okay.
Okay, so ASAM is the American Society of Addiction Medicine.
Correct.
And IOP is intensive outpatient.
Oh,
program.
That's right. Yeah. But, you know, that takes us away from, I don't say things like you got to go to residential for 30 days or you've got to be in IOP for 12 weeks. Nobody says that to a diabetic. No, right? Or, you know, think of, you know, when people call us, it's really unique because I don't think anybody has ever called a hospital, for example, and said to them, well, how long is your heart attack program?
Right.
You know, they don't say that because they know it depends upon how fast they get well. And addiction needs to be the same. I don't like it when people say to a person, you need to stay another 30 days. It would be a good idea as to tell the person why they need another 30 days. Tell them what their symptoms are. And actually, what are we looking for in terms of an alleviation of symptoms so they could move to a lower intense level of care?
Right.
That's the way it should be, but it's not. I think we have to go in this direction. Opiates have been the biggest thing, you know, everybody's talking about. And, you know, I see so many conferences, various treatment centers doing different things. Let's say you have a person who's opiate dependent. I mean, if a person's opiate dependent, let's say the person does really well for 3 years, let's say, okay? Mm-hmm. And let's say they pick up again. It doesn't automatically mean they have to go back to residential. It means the disease was in remission for some time. The symptoms became active, and now what do we need to do to place that person? Also, I think people like myself and friends who have been abstinent for a long time, I think a person like myself, other people, would benefit from an annual recovery checkup being done by professionals. If you get back to that opiate person, let's say somebody lays out a really good treatment plan. If that treatment plan ends in 3 years, why wouldn't the person pick up? I mean, they have an active disorder that's not receiving treatment. You stopped it. If anybody asks, what would happen if you stopped treatment for a diabetic? The answer is they'll get very sick.
Right.
Same for hypertension. They're going to get very sick. But what we do, we stop treating people. And if they do pick up, we treat it as a brand new occurrence. Go back to residential care, first step, meetings, tell your story, what have you. We really do the same thing over time. I'm going to do the same thing for my cold in a couple of years. my chronic disease needs to be treated differently. I'm kind of rambling on, but I do get into this stuff.
That's okay. You know, one of the things that strikes me about this idea of, as an industry, how we describe it as a chronic illness.
Exactly.
But we treat it as an acute illness.
Right.
You know, one of the things that we encounter as addiction professionals, invariably when we talk to family members at the beginning of a treatment episode, they want to know, when is this going to be better?
Right.
The attitude that they bring to the situation is that it's an acute problem.
Right.
And so I think you're right. I think generally speaking, as a industry, we might verbally tell them that that's not the way to look at it.
Oh, exactly.
But then when Johnny picks up, well, you know, he just wasn't listening.
Johnny did a bad thing.
Right.
That's exactly. And it becomes punishment.
Right.
He did a bad thing. It wasn't the symptoms of a disease that probably became recurrent because they weren't following a recovery plan.
Right.
And a lot of people do that. You know, get back to that person who comes to my office. I'm going to recommend the level of care they need now.
Right.
And let's say they go through all levels of outpatient, and they might do residential treatment. Then they'll probably go through another array of outpatient levels. But, you know, that takes a year. I think that person maybe have another checkup once a month, go to once a quarter, go to semi-annual. I think anybody in recovery can point to times where it was difficult. So let's say you're going on in recovery, you hit a rough spot. You know, maybe you lost your job. Somebody close to you passed away. Those rough spots, they often lead to symptoms being active.
Right.
And if we had those checkups, don't you think we'd be a little bit more likely to figure that out?
Absolutely.
So when I say lifetime, if a person comes to, when I say you need to be in treatment forever, then they run away because they think I mean putting them in a treatment center forever or forever in IOP.
Right.
Treatment. We're always in treatment. The only thing that changes, or that needs to change, is the intensity of care.
Right.
And if we could take what we're doing now and just kind of do that, I think that would be really good.
But I think you're right that a lot of it is it's going to necessitate a change in the way we as professionals think about this whole thing. And here's a major obstacle that I've noticed in my career, which, you know, I was talking to a friend of mine about this earlier today, who's not in the world of addiction.
Right.
She's supported me throughout my recovery, which, you know, has been a long time.
Right.
And I told her, you know, I started noticing about 20 years ago, working in treatment, that a lot of times counselors, especially, well, I mean, and this almost exclusively applies to practitioners who themselves are in recovery from an addiction.
Right.
You know, it is such a sacred sort of occurrence.
Right.
To get sober.
Oh, yes.
And to get better. It's such a positive, life-changing experience.
Right.
That the person who goes through it, there's such an emotional attachment to what happened, what I did to get better.
Right.
And a lot of times what you see is when those people go on to become therapists, then they're working in a treatment facility and they look at every client through that lens.
Of course.
And they might not verbalize it. They might not articulate it. But what they're thinking is, he's not doing what I did, so he's doing it wrong.
Sure, absolutely.
It happens all the time.
I know.
All the time.
I know.
And there are facilities that, I mean, they're basically built around that concept.
That's true. We can look at it now and sit here and say that that really doesn't make sense. But that's the culture we grew from. I mean,
Right.
let's face it.
Right.
When Bill Wilson and Dr. Bob, something really good worked for them,
Right.
and then it got spread around the world. It's
Right.
amazing what they've been able to do. But it's kind of like that's what you said. That's what they did.
Right.
No, everybody else is doing the same thing, and the culture was right. I mean, addiction treatment got brought up in a culture of temperance, bad attitudes. In fact, I think we watch gangsters on TV, usually black and brown ones, they're the drug addicts, not
Right.
white people like
Right.
us, let's say. So you got to look at the culture. It's not that people, the culture got us to where we're at today, and I think the culture needs to change.
Mm-hmm.
And that tends to be what happens. Things evolve.
Mm-hmm.
I hope I'm still making sense to you.
Yeah, absolutely.
Okay.
But I think, there is when as a practitioner, you look at a client through that lens of
Right.
this is how I did it. So if you're
Right.
not doing it my way, you're doing it wrong.
Right.
That's not really a humanistic way to look at the person. That's not always a
right.
fair
Yeah.
way. Because the truth is,
Yeah.
and I was, one of the things I like to say is there's a screw for every nut.
That's true.
And everybody who goes through this process
Right.
has their own variation of the process that they go through.
Of course.
It's their own sort of formula that
Right.
they find that works for them.
Correct.
And we tell people that's a lot of times we tell them, but then again, a lot of times people get caught up in this is the way I did it.
Right.
And here's what I think, where I think we miss the point about that.
Okay.
So, for example, there are facilities out there that have a certain way of, using the steps, the 12
Right.
steps to take people through this process. And this is what we do. And this is who we are. And
Right.
kind of have this attitude that if you're not doing it this way, you're doing it wrong.
Okay. And
I know you've seen this. You've seen this.
I've seen it, and I've seen some really bad things happen. Like, okay, you're not doing it my way. You just got to go out and do some more research.
Right.
Well, what do we mean by you got to go out and maybe kill yourself?
Right.
And that's basically what it comes to. And could you ever imagine a medical professional saying that to a patient?
No.
You got to go do more research.
Right.
Or the one I like the most is I'm not going to spend more time in your recovery than you will.
Right.
Why would you expect the person who's probably in denial and doesn't want to
even-
be there in the first place? Why would they have much interest in getting abstinent?
Right.
I mean, the motivation, when we say, I'm not going to give you a lot of my time because you're not doing, we're really putting the person down.
Yeah.
We really are. It's shaming.
Yeah. It
Go
is.
out and do more research. It's shaming.
But just to finish my thought here. So where I think we're missing the boat on this is that first of all, the facilities that are grounded in some philosophical system of
Correct.
how we do treatment
Right.
are far and away better than the ones who don't.
Oh,
They're just
sure.
kind of doing
Yeah.
it. And there are a lot of places out there
There are
that are
good
just kind of
places.
doing it willy-nilly.
Right.
But the places that are grounded in a philosophy tend to be better. So they
I
do
think
get
so,
good
too.
results. And
Well,
but
that's-
the thing is that doing it this way, because this is the way we do it, what is effective about it from my point of view,
Right.
and having gone through a great treatment program
Yeah.
myself, isn't about the formula of what we did. It's
Right.
not about what we did.
Mhm.
It's about because we did these things, we became part of something bigger.
Right.
We belong.
That's
to
important.
something.
That's really important.
That's what it is.
Yeah, I know. But you could belong to. I don't think anything really has to change that much on our part. You said we get results. I'm not sure about that. If you're at a conference and somebody, or let's say a person is seeking admission, and they say, "Well, how successful are you?" What they're really asking is something like, what percentage of your patients are still abstinent in a year? That's kind of like the question they're
Right.
asking. How successful are you? That's a horrible way to measure success. The American ASAM, American Society of Addictions Medicine, basically would consider a person certainly not a failure. As long as they're engaged in the system, they're not a failure.
Right.
Let's say I have a person I'm working with who I see monthly. Let's say they pick up. Does that mean they're a failure? No. But we create failures. Person, let's say I'm seeing that person. Let's take a person who's 30 years old. And let's say they're going to be on the face of this earth for another 50 years. And they go through treatment the way we do it now. And they really learn that relapse is a bad thing. You know, when you're in treatment, you do all these kind of exercises for relapse. You go to relapse prevention groups. The worst thing that can possibly happen is relapse. So you have a person who's 30 years old, and let's say they're going to be around for 50 years. That person has a chronic disease, and the expectation is that those symptoms will not become active for the next 50 years. It's the only way to do it. If they're abstinent for 30 years, you got to start all over. It's like you never did that in the first place. When I talk about shame that we create, that's part of it. Treatment, by the way, even you and I, no matter how much I try to apply it to the whole thing, I'm still, I've been around a while. Change
about
is
residential
hard.
treatment one.
But symptoms have a way of recurring.
Right.
And if we get rid of this relapse, which I prefer to call recurrence, if it wasn't such a horrible thing, isn't it likely a person might call somebody the next day and say, hey, I went to this wedding, got drunk, what do I do now?
Right.
If there's no shame, but we create the shame. We create a lot of it. Everyone in our field wants the stigma to go away. We're the ones that have to change, not the rest of the world. I go to meetings where they say, courage to change the things I can, accepting that I'm powerless over. I can't change the rest of society. I could change how I treat people when I'm working with them, and so could all of us. We could stop looking at the insanity of expecting a person to have a lifespan disease and never have the symptoms become active. It's irrational. Change will take time, but I think it's happening,
Yeah, it's definitely it's an interesting industry.
It is.
And
we've helped millions of people.
Yeah.
And that was a guy who was leaving treatment when I was working full time at Seaside Palm Beach. And this fellow was leaving residential care. And he was going to an East European country, Bulgaria. He was going, and we decided to see if there were any AA meetings in Bulgaria. We didn't know what to expect. I was amazed to find 8 English-speaking AA meetings in Sofia, Bulgaria. I mean, how does that happen? A lot of we've got amazing people like you and I. They saved our lives, right?
Right.
What about the people who we've tossed away? What about the people we said, well, you don't want this bad enough, so I guess you got to be out there. You don't want this bad enough, or else you'd be going to AA meeting. I think we've helped millions. How many did we turn away? How many did we turn off?
Right. Well, that's what you're describing, is kind of my pet peeve with addiction treatment. And, I feel like if you get paid to help people recover from an addiction, to tell a family member that they must not have wanted it badly enough,
that's right,
is a crock of shit.
It really is. It really is.
It's a cop-out.
It is. It's a cop-out. But I'm glad to say there are a number of people thinking along these lines.
Mm-hmm.
I mentioned Michael Botticelli. I mentioned David Mayley. These are people who have an impact.
Mm-hmm.
I'm not. Patience has never been a great virtue for me, but it's happening. I do know treatment centers are using language, not necessarily saying it's a relapse.
Mm-hmm.
I think some progress is being made. I have a friend of mine who talked to me about that. It was, I guess I could say, Terry, who you've had a podcast
Mm-hmm.
with. He talked to me about how he maintains his abstinence. He uses 12-step. His spirituality comes from being Jewish and observing. He has a medical doctor who knows how to treat addictions medicine. So you have a person who has a way of being checked on forever, medically, spiritually, and being abstinent.
Mm-hmm.
I've talked about recovery checkups being a formal process. But if people start leaving, you're right about what you said before, because when I talk to people about, you're right, there's a fervor, an emotional.
Right.
I facilitate smart recovery meetings. I started doing that because people I was working with, half of them would go to 12-step, half refused.
Explain briefly smart recovery to
Okay.
someone who doesn't.
All right.
It's an alternative to 12-step recovery.
Yeah. They prefer not to be called an alternative because that almost means 12 steps first. And if they don't make it, they could try smart.
Okay.
Smart, the goal is abstinence. It's based on cognitive behavioral therapy. SMART does say they will work with people who are trying to achieve abstinence. In Palm Beach County, there's 7 or 8 SMART meetings a week, 3 up in the northern end and 4 or 5 down in Delray. At a SMART meeting, thought out, people go around. I might say, "Hi, I'm Michael." I don't say, "I'm Michael, I'm an alcoholic." I would be asked if I want to put something on the agenda for discussion. Let's say, I'm having a real bout with anxiety. So that goes on the board for discussion. So everybody says hi. Everybody has a chance to put something on the agenda. Then for the most of the meeting, it's called crosstalk. We talk to each other.
Mm-hmm.
So if I said I'm having trouble with anxiety and you were a group member saying, I've had some trouble with that too, this is what worked for me, it's a face-to-face conversation. And Smart Recovery is a handbook that's really helpful to people. And actually that handbook is used by 12-step therapists and cognitive behavioral therapists because the exercises are just good.
Mm-hmm.
It's broken down into 4 categories. There are exercises in there to maintain your motivation, cope with urges, solve your everyday problems, and then live a balanced life. Spirituality is not part of Smart Recovery. Now, that doesn't mean, I'm part of Smart Recovery. I consider myself spiritual.
Mm-hmm.
Spirituality is not part of Smart Recovery, but it doesn't discourage anybody from growing spirituality.
Mm-hmm.
Spiritually. And I think Smart is talking more about religion rather than spirituality. Right. Sometimes I think they did that just to stop people from arguing with each other,
Right.
They don't take a stand on whether it's a disease or not because the goal is abstinence. So we go around, we talk to each other. After about an hour, if I'm facilitating, I say, would anybody like to check out? That would give everybody there a chance to say, hey, I really like this tool we use. I'm going to use it. Gives people a chance to say what they're taking with them. People often go to both Smart and 12-step.
Mm-hmm.
You can go to Smart for cognitive behavioral stuff and you get your spirituality from 12-step. Pretty good marriage.
Mm-hmm.
And a lot of people do that. But when you said, we got to do it my way or this way, there are some people, I don't know, they really they dislike Smart intensely.
Mm-hmm.
It's not looking to harm anybody. there are other, right now, there's Celebrate Recovery. That's a different direction. That's
Which is a
very,
Christian-
very Christian.
Yeah.
That might work better than AA or SMART for one person.
There's
I think-
Refuge Recovery, which is
Refuge.
Buddhist.
And it's here too.
Yeah.
I think there's a couple of me.
There's a number of them.
And people can, and early on, not only did I think I had to go to AA, I had to like it a lot. I had to love it.
Yeah.
And if I didn't love it, I wasn't going to tell certain people who suggested I go.
Right.
AA saved my butt. And I was never, I'm not a person who says I loved AA. AA helped me stay abstinent. AA was the only kid on the block for a long time. SMART, Celebrate, Women in Recovery, Refuge. People have options.
Right.
And I think that's important. I think I'm going.
Well, no, it's okay. I mean, this is kind of how I do things.
All right,
Just
good.
go where we go, but I think one of our big problems in the industry, I know, and well, first of all, let me just say a big advantage for me early on in my recovery was this recognition that I had that this is an ongoing process.
Oh yeah,
I have to keep getting better.
Right.
So it's kind of another way of saying what you're saying.
That's true.
And for me, it's about continual growth.
I believe
and I
that's
accepted that very, very early on.
That's true. It's a good point.
So there's that, which, I think is important to acknowledge. So one of the things that I try to do with clients that no one ever did with me,
right?
This idea that you thought you had to like 12-step meetings,
right.
And you weren't going to tell certain people if you didn't because you were going to get an earful about it.
Exactly.
Essentially be shamed about it.
You got it. That's a good point.
And now, I work with mostly young men.
Yeah.
I mean, the people showing up in addiction treatment are young.
Oh, very young.
And so when I sit in a group full of guys, like right now I do a group once a week with guys who are between 16 and 22.
Wow.
All of them. When I got sober, I was 23 and I was the youngest person in the joint. I mean, my roommate was 68.
Yeah.
I mean, there was like one other guy in his 20s. I mean, it's not like that anymore.
I know.
So that's another reason why we have to change.
Oh, I think
because
so,
the
too.
age of onset is different. But
yeah,
I think what really lies beneath all this is codependency, a symptom of which is an inability to experience reality.
Right.
Okay.
All right.
So the reality is this sucks.
Right.
I found myself in a place in life where I needed to go to rehab.
Right.
Where I needed to leave my family.
Right.
And go drastically alter the course of my life. Nobody ever wants to do that.
Of course not.
Nobody ever wants to do that. And no kid wants to think he's relegated to a life in 12-step meetings where there are old men telling you to take the cotton out of your ears and stick it in your mouth.
Right.
Everybody's drinking coffee and smoking cigarettes.
Right.
That's not, and what, they're walking away from a fraternity and going to that.
Yeah,
that is not desirable.
I know.
It's not. So just the idea of validating their feelings instead of creating an atmosphere where they can't say, I don't like this.
Right.
Because if they do, somebody's going to tell them how wrong they are.
Right.
And that they're not going to be okay because they need to like this. That's a crock of shit.
I know. And, if you think about it for a while, it's very hard to sell somebody on something that they know they're going to be terribly unhappy with.
Right.
And I don't think, I don't think it would take much to change that. Maybe you say how we convey our feelings. Mm-hmm. Maybe we convey that, we've been doing this for a long time. I didn't want to do it either, but because I did it, maybe you should do it.
And that's what I say. Nobody, I didn't want to do this.
Yeah.
I understand that you don't want to do this. I didn't want to do it either.
Right.
That's okay to feel that way. It doesn't mean you don't try.
Exactly.
And you find your people. You find where you fit.
Exactly.
That's what it's about.
And like
finding what works for you.
And what you said before, you might find you're getting something from 12-step and something from refuge, and you might really enjoy Celebrate Recovery. Mm-hmm. That's your program. That's your lifespan recovery.
Well, and listen, the truth is, I mean, we don't have the corner on the market for this stuff. There are plenty of people who've quit drinking and gone to church.
That's true.
For centuries.
Exactly.
Now, this is just our way of doing it. And so it's pretty narrow-minded to think that this is the only way.
But I think we can. Change takes time. And what you were saying before about when a patient asks you, they ask you, well, what's your success rate? Let's say a family. I think as long as you're in the treating this disorder, you're successful. Mm-hmm. A person who treats the disorder well for 12 years, that person's done well. Mm-hmm. And let's say the symptoms recur. Okay, the job is what symptoms does this person have, and what level of care do those symptoms indicate? Mm-hmm. Person who's been abstinent for 12 years and picks up doesn't, maybe they just need to get back into some one-on-one therapy. Mm-hmm. Maybe they just need detox and are working such a strong self-help recovery that maybe all they need is detox. Mm-hmm. Maybe they need, I could go on. Maybe they need detox plus a whole bunch of other services like maybe yoga or exercise or.
Right.
I think we do really well as professionals. Most of my neighbors think it's a waste of time. A lot of my neighbors come up and say, "Hey, how effective is that thing you do anyway?"
Right.
Like they already know. They read about the people who start using. We've set up a situation that guarantees failure. I look at that 12 guys had 12 years and picks up. That's fantastic. If total abstinence forever is your criteria, that guy who just had 12 years failed. And that's not good. Mm-hmm. And I guarantee it's going to make him or her less likely to come back into the rooms.
Well, I'll tell you, I got to be honest. I sit here listening to you and I'm thinking, I celebrate 23 years in a few days.
Yeah.
If I picked up a drink, that would be fucking terrible.
Oh, it would be.
It would be terrible.
I would be crushed. And like I said, I'm talking this way, but I'm a product of the other way.
Me too.
And I find it, if I can talk to a person who's never come into getting well again, if I could start with that person, that's a good start. Mm-hmm. And one thing that I found, and you could try this with people, sometimes like at a high-end treatment facility, let's say something like Seaside, for example, a person might come to me and they just say, hey, this is my fourth treatment. And when I stop and explain to that person, well, not really. I mean, you were first treated, what was it, 15 years ago at this, Hazelton Equality Center, whatever, and you did real well. In fact, you used the tools you did whatever you're supposed to do. But if I say to him that it's the same disease, you stayed abstinent, the place you went to the first time may not have put together the best discharge program for you, or perhaps you didn't follow it.
Wow. But talk about another pet peeve.
Exactly.
I mean, that's like, there's a pretty good chance they didn't.
But you know why? Because it's called aftercare.
Right.
When they told me aftercare in 1983, I said, what? After what? Afterthought? No one ever creates the importance on what happens next. It's like what happens next may be more important than what just happened. Mm-hmm. When you look at the doctor studies and the pilot studies, great recovery rate for 5 years.
Mm-hmm.
Granted, some of those people need licenses and stuff.
Mm-hmm.
But those people perceive themselves to be in treatment for 5 years. The 5th year might be a semi-annual checkup. That's treatment.
Mm-hmm.
But so the intensity of treatment gradually diminishes. But I wonder what would happen if if I continuously perceive myself as a person in treatment rather than thinking treatment is something I did so long ago.
All right, that's Michael Weiner. We'll have part 2 of this conversation coming up here in a couple weeks. Hope you enjoyed it. If you did, please leave a review or a rating at Apple Podcasts or wherever it is you listen to the show. You can email the show at thepathtoauthenticity@gmail.com. You can join our Facebook community or follow us on Instagram, both at The Path to Authenticity. If you're interested in supplemental content, early access to episodes, you can become a patron on Patreon. That's patreon.com/The Path to Authenticity. So be back in a couple weeks with part 2 of this conversation. Got a lot of other good episodes coming up. Thanks for listening. Hope you come back. Be nice.
Great, honeybee.
The Path to Authenticity is powered by Equivox. For digital marketing and web design services, visit equivox.com.